So we sent a letter to your department, Dr. Watson, for your attention, saying it was sent on the 4th of February to ask for your advice. And then I thought, oh gosh, we're coming to this meeting today, so maybe I could bring it here if that's okay. Just not really sure what to do with this man he's 79, presented with memory problems with his wife, 2-year history after he'd stopped working, causing a lot of frustration at home, mixed short-term, long-term problems, struggling with names and faces, no apraxia, has aphasia, struggles with word retrieval, concentration drifting off when he's watching the telly, left school at 17, lives with his wife and has 3 children who live locally, can't manage new learning, executive functioning, his wife's doing all that now, forgetting to take his medication, getting irritable. So his mocker was, I've got all the information in front of me, his mocker was 16, which clearly was significant. His bloods were okay. And then his ECG was all right, checked it with cardiology because he'd been to cardiology recently. Then his MRI came back with a GCA score of 1, an MTA score of 1, and FASICA score of 1. And I'm thinking, well, I was really surprised at that MRI scan compared to his mocker. And I'm thinking, I don't know what to do now, really.
I'm going to hand this to Dr. Ali because he's looking after the Birches and he'd reply to the letter.
Okay, thank you, Dr. Harris. In terms of functioning, how is this patient?
Well, with the support of his wife, he's managing, but loads of frustration at home because he's just not remembering things. What did I tell you? I've written amnesia is mixed short-term, long-term. Agnosia, struggles with names and faces. Apraxia, there was no concern. Aphasia, he's struggling with word retrieval. Concentration is just kind of drifting off. New learning he's struggling with. Executive functioning, his wife's doing the shopping, the cooking, the cleaning, and the finances, and reminding him about his medication.
Are there any signs to suggest Parkinsonism?
No.
He
didn't have, he walked in fine. There was no tremor, no paucity expression. But I could revisit that.
Yeah. I mean, from what you have described, in terms of the significant memory and cognitive decline backed by functional decline. And I think what I'm getting from you is over the last 2 years, which I'll consider to be gradual. It's not uncommon to have the MRI scan to be unremarkable, really, in the early stages. I think I would take this to be, if there are no other signs to suggest other forms of dementia, I would take this to be Alzheimer's dementia.
Okay, then treat him. Give him some donepezil, see how we go. That's what I needed to know. It's just I was really surprised with that mocker, and the mocker and the history fitted nicely together. And then I was really surprised when I got that MRI scan back. So
we do get quite a few queries to the memory clinic from GPs who have done the primary care pathway. They've got somebody who's got a very good history of Alzheimer's disease, poorly performed in the mocker, but then a normal MRI scan. So it is something that is fairly common.
I think probably because most of them have got vascular changes on in my area. So yes, that's probably why it was surprising to get a normal one. Okay, that's really helpful. Thank you for that.
Thanks, Leanne. Thanks for sharing your case study.
And I think really the other question is, what's the way this clearly didn't work, sending you sending a letter through. How should we do it? How should we go about contacting you?
I'd still say the letters. Sometimes, do you say it was about the 2nd of February?
Yeah, so it's possible you've not seen it yet.
Yeah, because sometimes they go through the SPOE and then it takes a little bit of time to get to us. And then, unfortunately, we've got a few other, it kind of goes on to the non-urgent. We'll get to that when we've got the screen.
Yeah, I just wanted to check that, because advice and guidance goes through ERS for other departments, but not for you guys. And it was how best to make not a referral, but a request for advice.
Right. I think that might be something we might need to take back to our managers meeting, just have a bit of a think about that. So we've got a meeting next week. We could maybe bring that.
That would be really helpful. Thank you. Right, I'm going to turn my camera off because I'm finishing lunch. Thank you.
There's consultant.
Oh, sorry, Dr. Matthew, you're frozen.
So I don't know if that's any good for, you can sort of literally speak to a consultant the same day.
I'm sorry, there's a bit of problem with the signal there. We didn't quite get the first bit of what you said.
Sorry, there's a new initiative that's been rolled out, hasn't it, called Consultant Connect. And we're finding that quite useful, for queries, so small, like day-to-day queries like this, to get a quick answer without actually even having to wait for an advice and guidance request. So that's working across other specialties. I haven't tried it for psychogeriatrics or psychiatry yet.
Oh, we're not on that.
No.
Yeah, we're badly staffed. There's not that many of us to go around.
Consultant Connect seems to be working because there's 3 consultants on call. So one after the other, you just, if one is busy, you go on to the next, you get connected to the next and the next. So, but I haven't tried it for psychiatry yet.
Oh, is that with Northern Care Alliance?
It's Jennifer, it's anywhere in the country. Quite often you ring it up and you end up speaking to a consultant in London or in Southampton or somewhere, but it's other specialties mainly. It's quite, I've used it a couple of times, been quite impressed, but psychiatry isn't on there as far as I'm aware, or certainly mental health services.
Thank you. Jenny, I don't know if you wanted to start with your presentation. There is a comment in the chat about another case, but I think you were going to look at cases at the end, weren't you? So we'll finish at the end. So just as a reminder to everybody, this is the second session. We've had 3 training sessions previously from Dr. Watson and Dr. Campila, and Dr. Watson and Dr. Ali are just doing a rerun, and this is number 2 in the sessions, which is being recorded. So over to you, Dr. Watson.
Thanks. Can everyone see the slide? And
yes.
we'll stop being able to see the chat. So
I'll keep an eye on the chat, but if anybody wants to just ask questions as we go along, just pop your hand up or shout out. Feel free to put your cameras. It's an interactive session, so whatever is your preference.
So can everyone see the slide?
Yeah.
Right. So we're going to start off by doing a bit of a recap of the first session, and then we'll go on to talk a bit about different aspects of management of dementia. So, which the first case study, the case study there just nicely illustrated, is dementia diagnosis is mainly clinical. So you're very much based on what the clinical history is, onset and progression of symptoms, how those match up with different criteria for different dementia. Second thing is memory testing, look at how they scored on the MOCA. And the third thing is brain imaging, most commonly an MRI, and that can help you to identify the subtype of dementia that you're looking at. So we talked a bit about definition of dementia last time, and it's an acquired condition, usually progressive, and you get deficits in memory, language, behavior, executive or visuospatial dysfunction. Don't have to have all of those domains in order to make a diagnosis. There has to be a significant functional decline in the person's usual activities or work, and it occurs in a setting of clear consciousness as opposed to, say a delirium. Grading of severity, if we go by the ICD-10 criteria, and it looks at the impact of the symptoms of the memory decline or the other cognitive abilities on the person's day-to-day functioning. So in the mild stages, it interferes with everyday activities, but doesn't prevent independent living. So this person might sort of be occasionally forgetting to take the medication, struggling a bit with appointments, a bit of word finding difficulty maybe, but still able to drive, go about normal life. Difficulty learning new material. They might have, say, a new appliance around the home, like a new washing machine, a new television, and they just can't grasp how it works. Can't do complicated daily tasks or recreational activities, so things that maybe require a lot of focus or multitasking. And then as the symptoms progress and the person gets to the moderate stages, they're not able to live independently. So they're usually at this stage needing sort of more prompting with sort of prompting and help with dressing, a lot more prompting with appointments. Language is becoming more impaired. Highly learned are very familiar on the materials retained. They're starting to get lost locally, lots of difficulty recalling recent events. They're starting to have difficulty remembering the names of familiar people, although they'll still recognise the person, but they might get the fact which member of the family they are mixed up. Simple housework only, so more complicated things like baking or cooking, where they have to sort of focus and sustain concentration on the task, that might be more difficult for them. And essentially they're able to do less overtime and focus on it less well. And then when they get to the severe stages, there's a complete inability to retain new information, and really maybe if there's anything, they only have fragments of previously learned information, can't recognise close relatives, and there's rather not an unpleasant phrase, absence of intelligible ideation. So we talked a bit last time, and I think that the talk has been recorded and is available for viewing. So there's Alzheimer's disease, the most common type, then vascular dementia, then dementia with Lewy bodies, your frontotemporal, and there's others that are rare and we won't go into. So with the primary care pathway, you're going to be diagnosing and managing people with straightforward Alzheimer's disease, vascular dementia, or mixed Alzheimer's and vascular dementia. Anything else that's referred on to the memory clinic. So memory clinic referrals would be suspected frontotemporal, suspected Parkinson's disease dementia, suspected Lewy body dementia, people who are under the age of 65, people who maybe got comorbidities that make diagnosis a bit more difficult. So say they're on sort of very sedative medication, if there's depression there that's been treated and not resolving and is clouding the picture a bit. People with learning disabilities will also be referred, and although that's a bit of we're having some discussions with the LD team about who sees them. All right. So does everyone remember the risk factors for dementia from last time?
Age, cardiovascular factors, cardiovascular risk factors, hypertension, diabetes, and injury.
Good. So age is your biggest risk factor. So the older you are, unfortunately, the more likely you are to develop a dementia. Other risk factors are having a history of mild cognitive impairment, learning disability, particularly Down syndrome, family history, more important with young onset Alzheimer's disease, so people who develop it before the age of 65, less important in the late onset. As you said, vascular risk factors, so hypertension, hypercholesterolemia, atrial fibrillation, risk factors for both Alzheimer's disease and vascular dementia. having lower educational attainment, hearing impairment, smoking, obesity, depression, low social engagement support, high alcohol consumption, traumatic brain injury, and air pollution. So, symptoms of, that you see in Alzheimer's disease? How would that? What kind of pattern would we expect with that?
Sorry, I lost signal for a bit. I couldn't hear the question.
Oh yes, so I'm just saying, how would you expect the memory to decline in somebody with Alzheimer's disease?
So quite gradual, unlike vascular, which is step ladder.
Yeah. So insidious onset comes on very gradually, smooth decline. Short-term memory is affected initially, and then the longer-term memory in your later stages. And compared with people with vascular dementia, they quite often have poor insight. So they may not be aware there's a problem with the memory, or if there is, they are they're not aware of the extent of it. And then you got your 4As, your amnesia, aphasia, praxia, agnosia. And then with Alzheimer's disease, you can get different psychiatric symptoms. So there's higher rate of depression, anxiety. Very small number of people might present initially with symptoms similar to mania and can have hallucinations and delusions, but they do tend to occur in the middle to later stages of the condition. And then behavioral symptoms like apathy, agitation, wandering, physical and verbal aggression can also occur. And then you do get personality changes, but they tend to occur in the later stages of the illness, and there can be a wide variety of them. Some people don't change very much. Some people, personality change that they used to have get accentuated, or sometimes it can go the other way. Sometimes people can become very, very active, can become very, very, very placid. And then, as somebody was saying there, vascular dementia can get an abrupt onset, stepwise progression, possible partial recovery, a bit more nocturnal confusion, can see also emotional lability sometime. In the history, there might be a history of stroke, and insights can be relatively preserved. So more aware that there is a problem. So vascular dementia can either be caused by strokes, sudden large infarct, or by small vessel disease. And if that happens, you can get a little bit more of a gradual more of a gradual decline. Vascular dementia, you can get quite patchy deficits, so people can retain skills quite well in one area, struggle in another, and they don't quite seem to match up. Or maybe for example, they might get sort of long-term memory affected early in the condition. And then Lewy body dementia, you've got your Parkinsonism, fluctuating confusion, quite vivid visual hallucinations or illusions. Can be quite sensitive to antipsychotic medication. You might see a history of falls and also REM sleep disorder. And then frontotemporal dementia, group of disorders, characterized, you get early personality change early in this type of dementia, but the memory is relatively preserved early on, although the memory will decline, but it happens later on. The personality change can take different forms. Some people become very socially withdrawn, quite apathetic. It can go the other way and they become quite disinhibited. Some are a bit aggressive, a bit irritable, sometimes sexually disinhibited. There's a loss of judgment and insight. They can become quite tactless, and it can lead them quite vulnerable to exploitation, and also can lead to frequent legal difficulties. They can also present as new onset symptoms that are similar to OCD. So they might start with compulsive behaviors. They might become very rigid in their routines and when they'll do things. They may start hoarding items. They may also develop a sweet tooth. And then we talked a bit last time about differentials, so possible reversible causes that we might look at. Subtumoral hematoma, SLE, endocrine causes, Wilson's disease, neoplasm, vitamin deficiency like B12 and folate. And then differential wise, when we're thinking about delirium, mild cognitive impairment, pseudodementia. And you have lots of training on delirium. Going quickly. So mild cognitive impairment is another condition to be aware of, and that's when a patient notices a decline in memory condition and cognition, but it doesn't interfere, but not to the extent that it interferes with their activities of daily living or their social functioning. There's no treatment for it, but if I'm seeing somebody with MCI, I'd advise them just keeping as active as they can physically and mentally. About 15% of them will go on to develop a dementia. Conversely, 85% won't. So usually, if we're diagnosing that, I maybe get them back in about a year's time to reassess. And then pseudodementia is a presentation of depression. So depression can impair somebody's concentration. They don't take the information in, so they don't remember it later on. Very classically, if you're doing cognitive testing in someone with a pseudodementia, they give lots of don't know answers to questions that most people will get, even if they have a dementia. So, for example, they might not know which country, but they might say they don't know what country they're in. They might say they don't know which county they're in. Maybe biological symptoms of depression there as well. So, if you suspect a pseudodementia, thing to do is just treat the depression as you would normally, and then reassess cognition after that. Some people who are diagnosed with pseudodementia later on found to have a dementia. Other people with depression find it can be the other way around. And of course, people can have two things at the same time. Okay. An assessment, clinical history from patients. Crucially, you need to get a clinical history from an informant as well. You might have the initial screening tools, G6, SIT, and GP cog. And then in the history, looking at sort of past psychiatric histories, the history of depression there. Medical history, is there anything that might cause problems that we're going to be prescribing later on? Is there a family history of dementia? Is there anything that's being prescribed that might be causing or worsening the mental state? So things like tricyclics, opioids, antimuscarinics, anticholinergics, and so on. And then social history, things to think about, are they smoker, vascular risk factor, how much are they drinking, what's the support network they have around them, are they still cooking, if they're doing that, are they leaving pans on too long, are they forgetting to put ingredients in, doing things in the wrong sequence? Shopping, are they forgetting items? Are they buying items they've already got? Can they keep track of the groceries so they know when things are going off? Are they keeping up with the cleaning? We'll talk a bit more in detail about driving later when we get to the management section. And are they managing the finances correctly?
Dr. Watson, sorry, there's a question in the chat about would you start medication for mild cognitive impairment if the patient wanted to, or would you not because of the fear of progression to dementia?
There's not evidence that medication will help with MCI, so I wouldn't know. The only caveat to that is I have occasionally, if I'm not 100% sure it is MCI, or sometimes you get cases that are very, very borderline. So people will come along in the histories. It's not quite enough to give a dementia, but there's maybe a little bit more than you might be expecting with MCI. So sometimes I just have a discussion with the patient and say, it's very borderline. You meet criteria for MCI at the moment. We need to kind of reassess in maybe about a year's time. And sometimes given the option to start medication, but with the caveat it's not going to, if it's MCI, it's not going to help. I try and avoid that if I can, because it can get quite messy, because you reassess in a year's time, it's still MCI, there's still a medication they may not need. And then when do we stop? It can get quite difficult. So answer to that is MCI shouldn't be prescribing cholinesterase inhibitors or memantine for it.
Okay, thank you for that. Sorry, another question here we've got from Leanne, just asking, what is the MOCA score that would equate to an MCI diagnosis?
I'd say about 24 or above, I think.
Yeah.
Taking into account patients' education background and the clinical symptoms.
Thank you.
So physical examination excludes delirium. Are there any focal neurological signs present? Any vascular risk factors? And sort of test would do just to exclude any conditions that might be impairing their cognition, and also just if we're thinking about prescribing things would need. So brain imaging can be helpful to determine the subtype. Doesn't always give you the diagnosis. MRI is preferred to get a lot more detailed in terms of atrophy and in terms of small vessel disease. CT of MRI is contraindicated or can't be tolerated, and MRIs fairly commonly can be normal in the mild to moderate stages of Alzheimer's disease. So in that scenario, you're looking at what's on the history. Are the symptoms consistent with Alzheimer's disease? Is the day-to-day functioning impaired? When requesting an MRI, you'd request an MRI head done with the dementia protocol, and then the radiologist should give you a general cortical atrophy score, medial temporal atrophy score, FASA-CAS score, and they will sometimes give you a CODAM score as well. GCA is just what it says on the tin. What degree of general cortical atrophy is there? And it's not that helpful diagnostically. Your medial temporal atrophy can guide you about whether your patient's likely to have Alzheimer's or not. So as we're all sitting here, we're all losing brain cells, and our brains are all atrophying. So a bit more atrophy is expected the older that you get, and that affects how you interpret your MTA score. So in somebody who's younger than 75, a score of 2 or more is abnormal, and in somebody who's older than 75, a score of 3 or more is considered abnormal. And then we've got the FASA-CAS score, and that's a measure of the severity of small vessel disease present. So a score from 0 to 3 and score of 2 or above is more than expected for that person's age. A CODAM score is a score of a degree of parietal atrophy. Again, sort of 0 to 3, 2 or above is abnormal. Okay, right. So that's just a quick whiz through some of what we talked about last time. Any questions before Dr. Ali goes on to talk about management? No
question. Okay. Thank you very much. Now we move on to management. I think the way I approach management is to look at it from the point of history assessment up to the point of management proper. And the reason why I look at it that way is because whatever you are able to pick up in your history and during your assessment is going to inform what you are going to input in terms of your management. It's important to say that what you do depend on the stages and the symptoms that the patient is presenting with. With regard to dementia, it is important to mention that management is generally MDT. We look at things holistically, involving different agencies trying to support the patient. So, talking about medication for dementia, medication are generally licensed to treat Alzheimer's disease, the mixed type, Alzheimer's and vascular, Parkinson's disease, and the Lewy body type. There's no evidence to suggest that they are effective for vascular dementia. So, the first set of medication that we'll talk about today are the acetyl cholinesterase inhibitors. Under this group, you have the common one that we know we commonly use, donazepam. We also have the rivastigmine and the galantamine. They are licensed to treat mild to moderate Alzheimer's disease or mixed dementia, as the case may be. It is important to say that there is no evidence to say one is superior than the other, and the choice of any one of them will depend on what you are able to pick from your history in terms of your assessment and the symptoms that the patient is presenting with. If anybody has got any question as I go along, please do ask, or just pop something in the chat and we'll respond to it. Okay, still on acetyl cholinesterase inhibitor. We know that in about 50 to 60% of cases, they bring about stabilization, and in fact, a slight improvement in patient. I think some studies have also shown that apart from the patients themselves, the burden of care is also reduced. And when you look at the disease along the line of from the point of view of the carer, we know this group of medication can exacerbate bradycardia or LBBB. So one needs to be cautious in this regard. As a rule of thumb, second degree, third degree block, I am cautious in starting this medication. And major reading disorders. It's also important to say one needs to exercise caution as well when the patient is on a beta blocker. Okay, so to guide us, because we know that acetylcholinesterase inhibitor, they have a side effect of reducing the heart rate. So if the heart rate is lower than 50 beats per minute, I think it's safe not to just prescribe at all. If it's between 50 and 60, then we have to be cautious. And I think the way I go about it is start at a very low dose and then repeat the ECG in maybe about a week's time.
Dr. Ali, there's just a question in the chat about can they be used interchangeably? So if a patient, for example, you start them on donepezil and they can't tolerate it, can they try galantamine? Can they go on to a different medication? Kind of what's the timing in between the meds?
I mean, each person is different. I mean, I have seen cases where you start someone on donepezil, it doesn't agree with them, then you change to rivastigmine, then they do well on rivastigmine. And I've also seen cases in which you start rivastigmine and it's the same symptoms, side effect that they're going to come up with. I think commonly what we tend to do, for example, is it depends on the side effect that we're talking about. For example, if it's a GI side effect, I think what people normally do is they prescribe rivastigmine as a patch rather than oral, so to avoid that side effect, and most people will tolerate that. Does that answer the question?
Yeah, and I think we usually start with donepezil. Well, happily, it's the cheapest one, and it's a once daily preparation as well. We were asked by the commissioner several years ago for the next one in line to be rivastigmine, and as Dr. Ali says as well, it's available in a capsule and a patch form. Patch form, you might get less in the way of GI side effects. Galantamine's more expensive, and we've been asked to avoid prescribing it if we can. But if someone's had similar side effects with donepezil, with rivastigmine, they're going to have the same effects with galantamine anyway. So there's rarely a good reason why you might want to prescribe it.
Yeah, just to add that apart from cost in galantamine, I think I have seen it being used in a couple of patients before, and my overall opinion about galantamine is patients tend to get more side effects with galantamine.
Other thing about it was sort of swapping and changing. We'd only change if there were side effects. We wouldn't change from one to the other if the memory, it was just purely because the symptoms kept declining. So there's no evidence that switching from one to the other in those circumstances is helpful.
Okay. Okay, still on acetylcholinesterase inhibitor, we need to be careful in patients with COPD and asthma because they can trigger attack. When I was a trainee, my trainer told me that he has never seen one case. I have not seen a case, but yeah, it's in the literature that we need to be careful, really. Patients with stomach or duodenal ulcers, we need to be careful. I think it's a good idea maybe to protect the stomach. It's maybe omeprazole or things like that. We also need to be careful with patients with epilepsy because the threshold for seizure might be reduced. Now we move on to memantine, which is clearly a medication in a different group altogether. It's an N-methyl D-aspartate receptor antagonist. As per NICE guideline, it's reserved for moderate to severe Alzheimer or mixed Alzheimer and vascular dementia. We sometimes go straight to prescribing memantine when there are clear contraindications to prescribing cholinesterase inhibitor. And sometimes we sometimes consider adding a cholinesterase inhibitor to memantine in moderate to severe stage of Alzheimer's and mixed Alzheimer's vascular dementia. Still on memantine, we do not need ECG, but clearly we need the renal function before treating with memantine. There's need to keep an eye on the blood pressure because high blood pressure is a side effect. Just like as we have in cholinesterase inhibitor, memantine can also lower the seizure threshold as well. So as a rule, we normally use the EGFR as a function, as a renal function of note. And as a rule, if the EGFR is greater than 50, memantine is usually titrated up. Usually we start with 5 milligrams a dose and increase by 5 milligrams every week until we get to the maximum dose of 20 milligrams. However, if the EGFR is lower than 50, then we have to exercise some caution. So if the EGFR is between 30 and 49, we titrate to 10 milligrams. And we check if it is tolerated. After 7 days, then we might titrate to 20 milligrams. If the EGFR is between 5 and 29, we also titrate to 10, but we don't go beyond 10. And if it's less than 5 milligrams, then we do not prescribe. Any question at this point? Okay. So.
Oh, yes. So anyone who's diagnosed with dementia in Bury, as long as they're not living in a care home, they should be offered a referral to the dementia advisors. I think Paul Lobaz, I think he put the referral link somewhere that you can access it. I'm not quite sure whereabouts. It's an online form, and what they'll do is the dementia advisors work for the Alzheimer's Society. They'll get in contact with either the carer or the patient, give them more information about the diagnosis, give them information about things they might need in the future, like how to contact social services, how to go about taking out an LPA. They'll give them information about what's on locally for people with dementia. So they run some of the dementia cafes in Bury, and let them know what kind of activities are on. Like there's a singing group, and I think there's a walking group at one point as well.
Okay. I think just to add that apart from supporting the patient themselves, they also have support and interventions for the carers themselves. So you can refer onto dementia advisors for either patient support or the carer support.
And the dementia advisors, they also have a contact, a line that the carers or patients can contact them on. So if in the future that the carers have queries about what, I'm not quite sure what to do about this, they can contact the dementia advisors for some advice.
Okay, you will recall when I started talking about management, I think one key thing that I mentioned was the holistic way to think about management and the involvement of various agencies. It's commonplace to involve the adult social services earlier on to do an assessment and see where they can come in. I think social support can come in the form of provision of carers to support signposting to day centers where they can patients and carers alike can go. One for activities and to meet people with similar problems and share opinions and rub minds and also get information. Meals on Wheels provision for people with dementia who maybe not able to cook themselves, or there is a risk of them actually operating the cooker. Respite care. Respite can be for the patient just to, or for the carers to I mean, when someone begins to care for someone who has got dementia, there comes a time when a bit of getting away from the caring or support for some time so that the patient can move into a kind of a temporary placement. Then carers assessment as well. I think when carers are supporting patients with dementia, there's also need for them to be supported as well. I think what is common is as dementia progresses, the burden on the carer also increases. There comes a time where they also need help as well, and you might refer them to the social services for what we call care assessment for their own assessment too and support. Do you want to add anything?
No.
Okay. So driving, when the diagnosis of dementia is made, it's statutory for patients to inform DVLA of their diagnosis, and depending on the stage of the dementia, you need to inform the patient. You also need to inform family that they need to inform the DVLA of that diagnosis. DVLA will ask for a report from you. They will send a paper asking you to give them information, more information about the patient, and they will take a decision as to whether or not they are satisfied that the patient can continue to drive or the patient should stop driving. I think in any case, if you, as a clinician, you feel that the patient is not safe to drive, I think the onus is on us to inform the patient to stop driving whilst they hear from DVLA, basically. So if DVLA is satisfied about the condition, I think usually they renew their license every year. There's no bedside test.
No.
I think there is an organization called RDAC that also assess patients on behalf of DVLA. So still on driving, I think it's important to check the concentration of the patient during your assessment, apart from checking how they are doing on the activities of daily living. I think more importantly, you want to check their visual spatial skills, and this becomes very important when you are trying to make a sense of your cognitive test. And also clinically, you need to make a note of the level of visual spatial deficit that they have. In your history, I usually go back about 5 years to ask them about what driving has been with them over the last 5 years, whether they have had any accidents or whether there are cases where we would refer to as near misses. So ability to judge distances, keep to lane, react to unexpected events. I think Dr. Watson has carefully put the grandchild question there. And this is to say that, I mean, in your assessment, I think the key question to ask the patient or the family is that, will you be comfortable having a grandchild in a car with this patient? And that goes a long way. The answer that you're going to get goes a long way in what they think or what the patient thinks about their driving. Any question?
When I've assessed and asked the questions, so the experience I've had is usually the family member declines to come along because they don't want to, be perceived as the person blocking cutting the person's wings from driving. And the patient, well, 2 occasions they were sort of quite accepting of what was happening, but on other occasions it's usually the patient is in denial, and it's a big change for them to stop driving. And I find that it's not the easiest conversation to have, but it has to be had. And we have to tell them to stop driving when there are significant concerns.
Yeah, I think that's the importance of having a collateral history. I mean, more recently, I saw a patient that was telling me one thing, and the family member was eyeballing me, telling me another thing, but did not want to upset the patient. And at the end of the clinical encounter, I wanted the patient to sit in the reception so that they have time with me to say to me the way things are rather than what the patient has said. Yeah. So one needs to be quite sensitive to the family dynamics going on.
Most of the time I found that relatives are usually fairly honest with you, or fairly aware of when the patient needs to stop driving, and can be quite active about stopping them if needs be. Sometimes, as you were saying, they are a bit reluctant to be the bad guy, and be in front of them to say that they need to stop driving. So sometimes it's just about letting the relative know that they can contact you outside of the consultation to give the opinion. If what can be problematic sometimes is if the person with dementia has always been the dominant person in the relationship, and the partner may not feel able to tell them that they need to stop driving, or if they live in quite an isolated place and the person with dementia is the only one with a driving license, sometimes they can be a bit reluctant for that person to give up driving, because that might cut the couple off from different things. So if you're in a situation where we don't think the person is safe to be drive, kind of based on the history, based on performance on memory testing, even if the relative is saying that we think they're safe to drive, I think, as Dr. Ali was saying, it's just that you'd have to advise the patient not to drive until the DVLA have made their decision.
Yeah. Any other question? Okay. Oh, so lasting power of attorney. I think this is something that we usually do not want to leave till late. Once a diagnosis is made, I think it's important to begin to discuss this with the patient. This is a way of the patient saying that I know I've got a progressive neurodegenerative or vascular condition, and at some point in the process, I will probably lose the capacity to make decisions regarding various aspects of my life, including health, maybe finance, and to begin to identify who they trust, who is going to make a decision for them when they can no longer make the decision, or when they have no capacity to make that decision at that time. So we need to try to start the discussion once the diagnosis is made. I think this brings us to
the end of
slides.
So any questions about that?
Any question?
I think Leanne wants to come in.
How often would you suggest reviewing the patient once you've made the diagnosis?
I'd say once a year. It doesn't necessarily have to be done by a doctor. So it could be, say, a healthcare assistant, general review. Has there been a change in functioning that might mean they need a referral on to social services? Yeah.
And what would you do? Would you repeat a mocker and bloods, or would you just go by some discussion with the patient and the relative initially?
I'll just go by discussion with patient and relative.
Yeah, no, that's fine. We're trying to encourage our practice nurses to take over some of the follow-up. So it may be, Nigat, that we need to involve the practice nurses on future training. I know there's a template on EMIS to follow, but it might give them the confidence to be able to do it a bit more. They're doing the chronic disease follow-up.
Yeah.
Half of it's done anyway. A lot of them are the same questions, and I think it would take some of the onus off the GPs and not be double the work for the practice nurses.
Good idea. Yeah, one to consider.
Thank you.
Does anyone have any question or maybe a scenario or a case study?
I think somebody did ask to discuss the case study earlier. I can't remember who it was now. Mamuna, was it you? Yeah, do you want to come in?
Yes. Can you hear me?
Yes.
Oh, sorry, it's Nadine.
Yep. Hi. Yep. Thanks very much. Thanks for the talk, Dr. Watson. It's just about. I just wanted to mention about a case. Actually, got like a patient. She's 62-year-old, having issues like with her memory for the last 12 months now. Initially, she came in, she said that she's struggling with the agnosia, difficult to remember like the name of the actor she has been used to seeing on telly, having issues like with the concentration as well. We did like she said normally she was very sharp in the brain and remembering things, but now she was struggling. Husband says that she had to keep repeating what they've discussed just not long ago on the same day, a couple of hours ago as well. She mentioned she runs her own business, so she was under stress there. We did try her with some mirtazapine, which she said that did help her from the depression side as well as on the sleep side, but she was still struggling with her memory issues. She did her mocha, but that was 29. She scored very well on it, but she said that she did struggle in answering the question. She did took her time longer than she would normally would. So we did her MRI scan, which this was like a MTA score of 1. Fizeka was 0, so that wasn't very conclusive. The GCA score was 0 as well, which complained to her age, explained to her as well. But she's still having issues like still struggling with the memory, and that's is going on last 12 months. I've seen her a few times in between. She said there's no improvement with her memory. I have actually sent her a referral because she's under 65, send a referral to your clinic. So just wanted to see if there's anything else we could have a look at in the meantime.
I mean, the only thing maybe is just check, is she on any medication that might be impairing cognition, painkillers?
No. No, so when we saw her, she was not on any medication at all. She has been on a couple of SSRIs over the time, and but other than that, not on any medication. We just recently, when we did all her screening bloods, she found out to have type 2 diabetes. Now she's developed that. We just like borderline, so HbA1c of 50, and then cholesterol was high, so started to reduce like that cardiovascular risk. So started on statins. Now she only started in the last week. So no other medication.
Yeah, no, that sounds like one for us. Yeah.
Yeah. Shall we wait like for your memory team to have a look at her then?
Yeah, we've got a bit of a waiting list at the moment, so
Sure.
it might be a few months.
Sure. Thanks.
Leanne, did you want to come in?
Yeah, well, and what would you do with that sort of patient once you receive them?
One of our support workers or CPNs will go out, do an Addenbrook's cognitive examination. We bring them into clinic, go through history again. A diagnosis was still unclear. I mean, differential they're thinking about would be maybe pseudodementia, mild cognitive impairment, or early onset Alzheimer's disease. If it's still unclear about that, might ask our team psychologist to do some quite detailed neuropsychology testing with them.
Thank you.
Dr. Matthew?
Hi, it's Deepa. Hi. So I've got this 86-year-old lady with severe Alzheimer's, mixed dementia, Alzheimer's, vascular. So just regarding choices for, agitation, sundowning. She is on memantine. In terms of other medication, she's on an antihypertensive. Just bear with me. So she's on doxazosin, she's on lecanidipine, losartan. Would you have a favorite one, or would you try benzos, short acting, or
No, we'd avoid benzodiazepines if at all possible. First thing I just do, maybe this is something we should maybe have do in the next session, a bit about behavioral changes in dementia. It's not quite around diagnosis and so on, but it might be helpful to do that. But first thing is just make sure that there's nothing else that might be causing the agitation other than sundowning. So first thing, is there any problems? Is the patient maybe in pain? Is there any sign of constipation? Any sign of infection, delirium there? Has there been any change in environment recently? Anything that might be causing distress that way? Is any sign the patient's hallucinating, depressed?
Sorry, I lost a bit of that because of bad signal. But yes, I've no, sorry, we've gone through all of that sort of fairly thoroughly, and there's a pattern. She is at home. A few months ago, she was admitted with C. diff diarrhea, and there's the sundowning is happening more frequently since. So, and the family is very supportive. The home environment is quite secure. There's no changes there. And she's had bloods recently, urine. So I don't think there's anything else going on.
Yeah. Okay. So in that case, maybe with somebody that age, maybe start a low dose of promethazine, maybe sort of 10 milligrams up to twice daily PRN to start off with. Other options might be sort of slight sedating antidepressant like trazodone.
Yeah, so promethazine, I think, the daughter wasn't so keen because of the sedation, so maybe trazodone. Okay, thank you.
Leanne, was that a new hand?
I'm afraid it is. Sorry.
Oh, no, welcome.
Driving again, back to driving. Did you mention that there's somewhere that can assess driving?
Yeah, so there's a service called RDAC.
Can you spell it? Can you spell it? Or put it in the chat or something?
We normally refer to it as on the road assessment.
Because that's really helpful, because sometimes it's just impossible to negotiate. But do they have to pay for it?
No. So when you send a patient there, then they give them appointment, and they do what I would call a mini driving test. I think it lasts about 5 minutes, and they decide whether they are able to drive or not, and they will do a letter to you to let you know. I also inform the DVLA whether they have passed or not.
That's really helpful. Thank you.
Dr. Libbet? You're on mute if you're speaking. Deborah, are you there? Might be multitasking and gone off to do another job or been called. Has anybody else got any questions or case studies in the meanwhile?
Sorry, I think she's just messaged saying she can't unmute.
Oh, can't unmute. Okay. Deborah, if you want to pop it in the chat if it's a question. Sorry, in the meantime, if anybody else has got any questions or case studies. Joys of technology. When it works, it's fantastic, and when it when it doesn't, it's a nightmare. Okay, so it looks like it's another case study from Deborah, 78-year-old. Last 3 weeks, deterioration in behaviour. It's an Alzheimer's patient on memantine, 20 milligram. And Deborah's saying, done recent blood test, check urine, all's okay. What are the suggestions, please?
Yeah, I think the starting point will be bloods have been bloods are okay. I think what needs to be done is to also look around some other things in the surrounding of the patient that might explain the behavior of the patient. Is the patient in pain? Are they constipated? Any changes to the environment? If all of that is not there and the patient continues to behave, that will have a deterioration in behavior, I think my own starting point too is to prescribe something that's a bit calming and sedating as PRN, maybe up to twice or 3 times in a day. I mean, so my first choice will also be promethazine to start with. About depending on how big the patient is, 10 milligrams to 25 milligrams.
And Dr. Toes asked about whether there's alternative drugs in the same class as memantine. Unfortunately, no.
Oh, so Dr. Harris is saying have that charging 150 to 75. Oh, I have referred many patients in the past to have that. I've never been charged before, and I don't think the patient has been charged.
It's been a little while since I've referred someone there. Yeah. I think that the process of setting up an account with them is very straightforward. And again, it's not us that makes the payment to them, if there is one.
Any other question? Is Dr. Nadim still raising hands?
Sorry, I've had to transfer
Hi.
to my phone. Suddenly my internet's gone.
Hi, yes. I just want to ask about, like you mentioned about the memantine to up titrate the dose to 20 milligram. Do we have to go up to 20, and how do we gauge that Or sometime can we leave them at 10 as well? But how do we gauge the response to when to go up? Or are they fine now with the 10?
Yeah, I mean, you'd want to they can get the maximum benefit from being on the 20. So if the renal function's all right, we should be aiming to get them up to 20 milligrams. So if your eGFR is above 50, start at 5 milligrams, go up by 5 milligrams a week until you get to 20 milligrams. Below 30 and between 30 and 50, up to 10. If they tolerate that for at least a week, carry on up titrating to 20. And you hold at 10 if it's sort of below 30. You're not going to see any sort of dramatic response really to Dementia or even the cholinesterase inhibitors. They can keep people a bit steadier for a bit longer. So what you're really aiming to do is kind of keep them as steady as possible for as long as possible. Sometimes with Dementia, people can get a little bit agitated the first week or two that they do start it. That does normally pass, but if that does happen, slowing down the titration can be helpful.
There's that question in the chat about whether eGFR needs to be repeated after the week of 10 milligrams of memantine.
No, but I'd probably recommend just repeating on an annual basis. Unless the renal function is really ropey, in which case a bit more frequently. Oh, right. So if the renal function was already impaired, yeah, I maybe depending on what the eGFR is, say maybe below 50, maybe after about six months or so, you just need to know in case you know that the renal function is deteriorating, are you going to need to reduce the dose of memantine that you're giving the person or withdraw it altogether.
Dr. Watson, can you see the chat? I've had to go onto my phone, so
yeah. No, I think we've covered everything in the chat.
Sorry, any more questions from anybody? Case studies? Sorry, I can't even see if anybody's got the hands raised. My laptop's decided that it's not joining the internet, so
yeah. No hands up.
No hands up.
No hands up that I can see either.
Okay, so I think the next session is on the 4th of March, which is the final session. This session was being recorded. Now I've got a slight problem in that I've had to go over to my phone. I don't know. Leanne, would you be able to stop the recording on the laptop? I think we need...
What do I have to do? Just press the recording button?
Yeah, I think we need everybody to...
I think you have to do it.
Right. Oh gosh, this is going to be a problem.
Maybe we should just leave.
Right, I think, yeah. If we say that's the end of the meeting and everybody leaves, I'll see what I can do on my phone. Otherwise, I'll have to try and join back on.
Many thanks.
Thank you very much.
You're welcome. Thanks.
Thank you so much.
Thanks,
Thank you.
Jennifer. Thank you.
Bye. Bye.
Bye.